But if you haven't gotten your food, please, there's plenty out there, so please get something and enjoy it while we get to sit in at this panel today. My name is David Balat. I'm the director for the Right On Healthcare Initiative with Texas Public Policy Foundation, and we're glad you're here. This issue of physicians dispensing medications from their offices at the point of care, it's not a unique one. As you see behind me here, we've got a map that shows Texas is one of a handful of states that does not allow for the practice for the vast majority of our citizens in Texas. Nationally, it's been tested, tried, and found to be good policy. And what do we do here at Texas Public Policy Foundation? Within our center, we have a standard for good policy. And what that standard is focused on is healthcare outcomes while advancing the principles of liberty. We have an opportunity to implement this type of practice in Texas and be a part of a solution that will help so many be able to afford their medications. I encourage you to read over the published research. It's just outside the door, and it should be available online for those that are watching on YouTube. There are two bills that are in the current legislature that address this topic in the House, HB 460 and HB 1622. Both are promoting for patients to purchase their medication at the point of care. We believe we should trust patients, not government, to make financial decisions regarding their care. And this is one avenue where that can occur. With that, let me introduce our fine panel. We're going to talk about this issue, and it should be a fun back and forth discussion. We're honored to have Carter High. Carter received his Doctor of Pharmacy degree from the University of Texas at Austin in 2004. He's currently a partner with the Best Value Pharmacies of Fort Worth, and he serves as the Director of Legislative Affairs and is the pharmacist in charge for Rome, Texas location. He has served on the Board of Directors for the Alliance of Independent Pharmacists of Texas and is currently the President-elect. He lives in Keller, Texas. Thank you for being here, Carter. Dr. Josh Umbehr. He's not a Texan, but he flew down here from Kansas, and we're glad he's here. He graduated from the University of Kansas School of Medicine, completed his family medicine residency at Wesley Medical Center in Wichita, and after completing training and becoming a board-certified family physician, he opened Atlas MD, a practice that he had been dreaming about for nearly a decade. Atlas MD represents his ideal medical practice where he's able to shrug off the burdens and restrictions of government and insurance regulations. He's a regular on the Sean Hannity Show and regularly testifies before Congress. Thank you, sir, for being here. Dr. Kristin Held is a board-certified ophthalmologist and ophthalmic surgeon. She received her medical degree from the University of Texas Medical School at San Antonio, where she was elected to AOA. On October 1st of 2015, her practice became completely third-party free, including opting out of Medicare. I think that's worth applause. And she's developed a direct surgery and patient care model. She is the president-elect and on the board of directors of the Association of American Physicians and Surgeons. And we're also honored here today to have Representative Matt Shaheen. He serves the citizens of District 66 in the Texas House, and representing West Plano and far north Dallas. He serves on the Committee on Ways and Means and is a vice chair of the House Urban Affairs Committee. He's previously served 5 years on the Collin County Commissioner's Court representing the citizens of Precinct 1. He's consistently ranked among the top most conservative pro-business legislators in Texas, and he is also the author of HB 460. Thank you, sir, for being here. Our moderator today, Dr. Deane Waldman. He's a distinguished senior fellow here at Texas Public Policy Foundation. He's a retired pediatric cardiologist and system theorist, analyst for American healthcare. He's the author of a recently released book, Curing the Cancer in U.S. Healthcare. Dr. Waldman, thank you for being here today, and we look forward to the panel.
Thank you. Am I on? Are we on? Good, thank you. Thank you, David. This is, I hope, going to be fun. Dialogue is always what I consider enjoyable, I guess. Born and raised in Manhattan, arguing is in my blood, so let's get started. And I want to clarify one thing. The title here refers to the affordability of our medications as consumers. But there are two other issues that I want us to keep in mind when we have this discussion. One is the issue of, does the patient actually get the drug that the doctor wants that patient to get, or does somebody else actually force a different drug on the patient? And number two, the question of medication adherence. Do the patients actually get and take the medication in proper form and in proper time? So keep that in the back of your mind, because we're going to be talking mainly about money, but I want to keep in mind that at the end of the day, it's patient care and patient health that really matters to us. So as a physician, certainly we all know that in order to cure a patient, you need to know the reason why the patient is sick, what we call the etiology or systems theory calls the root cause analysis. So let's start with why. Somebody can pick on this question. I'll save Representative Shaheen for when we talk about solutions. Why drug costs are so high as to be unaffordable for many drugs that patients need. Who wants to start?
I'll go ahead and lead off.
Please, Carter.
One of the challenges that we have seen over the last years with the rising drug costs, there's been a big shift in generic manufacturers, both on generic side and brand side, in terms of those companies getting gobbled up. And the lack of competition in the generic manufacturing space, the dwindling number of manufacturers has dwindled down because of consolidation attempts. We have seen generic acquisition prices go up well beyond a natural inflation rate, and that has caused a lot of problems, and unfortunately that does get passed on to the consumer.
So you're saying a move toward, if you will, monopoly is what is driving prices up?
In for the acquisition cost of the drugs, yes, both on the generic side and on the brand side. Every year, usually towards the end of the year in December, pharmacies can, through various wholesalers and various websites, can get a hold of the price increases that are going to be for a certain line of medications, and if we see those, we will typically try to purchase extra of those so that we can, obviously not have those prices get passed on to the consumer in the end.
Josh, Chris?
I think the issue of increasing prices is the same across the board, really, but maybe not always recognized. I'll be first to say the conversation can lend itself to feeling like we're demonizing insurance companies a little bit, but insurance is a great tool when used appropriately. We have car insurance for major accidents, but not for gasoline or windshield wiper fluid. I've got life insurance, but it doesn't cover groceries. We're using health insurance in the wrong way, and we're asking it to pay for medications that are a penny a pill. So of course we're going to see a problem there. All the increased bureaucracy, the paperwork, the regulation, the pharmacy has to call back to the doctor to get a different medicine, and the inflated price because of all the inflated work leads to the cost of those. So if we can eliminate by simplifying, Da Vinci said the ultimate sophistication is simplification. And if we can move the whole system in that direction, we'll need less insurance. Then we can get this back down to a spot where pharmacies and physicians can run very lean and efficient practices, but patients also aren't required to jump through all the hoops because they're not asking their insurance to pay for every single medicine. So in a weird way, using less insurance is the best way to make insurance affordable. But we've always been afraid that less insurance means less care. And we want to be very clear that those are two separate things. Insurance is a card in your wallet. Health care is access to your providers, your nurses, your physicians, your pharmacists. So if we can find innovative solutions that bend or break the cost curve, first and foremost, then we can put the cart back behind the horse and need less insurance, but not sacrifice quality of access there.
Chris, you have anything to add here?
I do. I think that we have, as we mentioned, approached a monopsony or a monopoly situation.
Right.
And since the 70s, the cost of drugs have gone up 13,000%. And why is that? It's because of the increasing intrusion, thank you, the increasing intrusion of multiple layers of middlemen. And a big thing happened with the group purchasing organizations getting an exemption from an anti-kickback statute from Medicare that created an uneven playing field. Whenever you have an uneven playing field coming down from government, then you start to develop problems. And an offshoot of that was that the group purchasing organizations that buy drugs and devices on the inpatient side got that sort of protection and exclusion from anti-kickback punishment and passed it on to pharmaceutical benefit managers. So now you have this group of middlemen that's not going to be paid by the buyer, but they're going to be paid by the seller. And so we have this complex insurance situation where people have to go to their formulary, select a drug, and the drugs on there are not necessarily the ones that the doctors think are best or they're the most reasonable, but they're the ones that perhaps there was somewhat of a pay-to-play scheme to get your drug positioned onto the formulary. So when you have a drug maker having to pay to get their drug put into the market, you have an abnormal supply chain, and the next year they have to raise the cost of their drugs. So now we have drugs that should be low cost being high cost. Patients are paying probably 30% more per drug, and they're paying higher premiums, they're paying higher deductibles, so it's becoming impossible for patients to get the drugs they need. And by what Josh has done and innovated and found a way to go around that, work around the middleman, has been extremely important for his patients and exemplary for someone like me who's practicing in Texas.
Let me just add one little piece of tinder to this fire, which is the statistic that if you look at healthcare spending in the United States, you will find that somewhere over 40% of all healthcare spending has no impact on care. What I'm saying indirectly, which I'll now say directly, is it goes to regulatory bureaucracy, insurance administration, compliance oversight, and all sorts of things that have nothing to do with the welfare of a patient. And quite frankly, what I think Josh is doing and what we're trying to do is reduce that cost burden that doesn't help patients in any way we can, which leads me, of course, to a question, and now I'm going to throw this, my friend on the end here. We're talking about physician dispense. That's one of the issues or potential solutions. So before we get to is it good or bad, how does it work? Tell me that from your perspective.
Well, you better turn me down. I've got a big mouth. And thanks for TPPF for being here. I love coming to these events. So, we have a bill that would allow doctors in the state of Texas to dispense medications at their practice. And I wish I could tell you that I was like this really smart guy that did a lot of analysis and read studies and came up with this idea. The reality is that 10 years ago, I woke up in the middle of the night and I felt horrific. My throat was just raw and I couldn't swallow or anything, couldn't sleep the rest of the night. So I got up that morning, pulled myself out of bed. I mean, I just felt miserable. We've all been there, right, with strep throat. And so I get to the doctor does the culture, sees I got strep, writes up the script. Then I got to get in my truck, go over, drive to the pharmacy, give the script to the pharmacy. I go back in my truck. I go to sleep just because I'm hurting so bad because it's going to take 60 minutes to fulfill the prescription. Wake up, go back, get my medication, go home, take it, and go to sleep. And so really, I looked at this from a convenience factor. And so the legislation is very simple. It's just a couple of pages, but essentially allows doctors to dispense medication. There's some provisions that we're taking a look at. We're talking to some of the pharmacy associations and all those types of things with respect to making sure that the patient understands that this is just one of other options and that there's pharmacies that are nearby. So if they want to go to a pharmacy, they certainly can and have that option. Really what this piece of legislation is doing is it's in response to what's happening naturally in the healthcare industry. As you've heard, this is a very complex industry, and we haven't even touched the surface. Think about outside of doctors and hospitals and clinics and all those components. This is a very complex industry by itself. And then you got the government who's infusing itself into that whole complex process to begin with. So as we talk about physician dispensing and those types of things, I think one of the things that we need to keep in mind as policymakers, as people in the industry that know the industry, is the market, this industry is moving towards solving these issues that we have, and really what we need to take a look at is the context of the government pulling itself back and getting out of the way. When you get a bunch of politicians into the process to try to solve problems, we end up fouling it up far worse than anybody in the industry can. Well, thank you.
Let me throw this over to Josh, who actually does this. Is that correct?
Correct.
All right. Tell us about your experience, and more important, your patients. I hate to use the word consumers, because for us, they're patients.
Right.
Okay, but they consume our services and our goods. So whatever word you want to use.
Well, we started our practice September 2nd, 2010, with the idea that, again, we could make health insurance less necessary if we fixed the price of health care. So we created a membership model. Other doctors in Texas, like Dr. Mike here, do it as well. Prices will vary, but roughly $10 a month for kids, $50 a month for most adults for unlimited home visits, work visits, office visits, telemedicine, no co-pays, free procedures, and then medications and labs wholesale, up to 95% savings. And the idea there is, how do we bring value to the consumer, to the patient? How do we show something that justifies the cost of our fees? Patients don't like to pay every time they go. No one wants to get a big $300-400 urgent care bill, but they want to be able to text their doctor when they're sick, and they want to be able to get care very quickly. So we were trying to problem solve cost and convenience and access for all of our patients, and this was a big piece of that. We are lucky to be in Kansas that allows physicians to dispense medicines. We've been able to get a lot of things for a penny a pill. There's a blood pressure medicine. I can buy 1,000 pills for $4.90. I can't get 1,000 rice for $4.90. Then we've been able to get breast cancer chemotherapy for $6 a month. Not because we routinely prescribe medicine for breast cancer, but the patient was diagnosed and went to the oncologist, and the team approach saying, okay, well, this is the best medicine for you, go to the pharmacy, and they ran it through their insurance, and that was their copay. Well, if your copay their copay was $600. So the system is broken when you're trying to use your insurance, and it's resulting in a much higher cost. But again, everybody else has a higher administrative cost. So for all of the complexities that have been mentioned, it kind of explains why there is this problem. And I think we see that problem more with big retail pharmacy than the independents. The independents are on the same side. We share that common ground of working for patients first and trying to find the best value they can. And I would say the same for my physician colleagues who would try to provide cost-effective care, but it's so difficult when they have 5 to 7 employees each versus our half nurse per doctor full-time equivalency. So our overhead's better, our prices are better, we can share those prices, those savings directly with the patient. So we routinely stock 200 to 300 different meds plus variations on doses. We can work with the patient on cost. They don't have to pay at the time of service. So we try to be very patient-forward, patient-obsessed in providing that value for them. We can mail the medicines out to them, but then we can also work with their employer, which is often a small business, and their insurance company to show how to decrease their premiums by 30 to 60%. Rough math, 30% of your premiums are copays, and another 30% are the amount the insurance is spending on medications. So if CVS is getting to mark up a medicine 1,000%, you're paying for that next year in your insurance premiums. So if we can problem solve and innovate directly for our patients, then we can solve a lot of downstream problems.
I'd like to throw just something in, and then we'll continue this conversation, which is Representative Shaheen said that healthcare is very, very complex, and then we listened to Dr. Umbehr talk about what is the simplest and what is the proper, if you will, complexity of healthcare, which is one doctor, one patient, the door's closed, and the doctor and patient decide on something, and the least amount of others in that process is in the best interest of the patient and the best interest of the cost curve, if you will. That's just Dr. Deane's opinion, but my colleagues are nodding their heads in agreement, so there you go. Now,
to follow up on that point, I think when we make healthcare expensive, then it's a self-fulfilling prophecy. If labs cost $1,000 through your insurance, but they're only $30 with us, you see two very different worlds that exist. When it's $1,000, boy, that's rough. I'm glad I have insurance. That's close to my mortgage. So then the conversation with the doctor gets messy because more people get involved. But if you don't ask other people to pay for it, you have a whole lot fewer middlemen in the room. Now when you can bring that down to a blood test for $1.65, check for your diabetes for $2.25, and I can get 1,000 metformin for $11, I can treat you for almost a year depending on your dose, then you don't need a middleman. Now it's putting the power back in the patient. They get to have that decision because there's no need for another payer to say, well, we don't let you have that metformin because that's too expensive. We've negotiated for this version. So we, remove stone and find the statue here.
We just heard from a general practice, a general physician, outpatient physician, but I think I need to throw this to Dr. Held, who, like me, is more in the hospital doing procedures, things that are much higher cost, and we involve drugs that are, quite frankly, rather expensive. What about physician dispense in that area?
Well, I'm in the hospital less and less. I'm in the ambulatory surgical center and the laser center, and then I see patients over 4 generation spans of their lifetime in my office. So having gone direct pay, in that respect, I've been able to lower the cost of patients having surgery directly with me, including Medicare, way down. I can do cataract surgery, including 3 months of post-op care for $800. And what happened, I have a little visual here, and what really prompted me with the drugs is I don't want my patients to have post-op complications. I have to treat them with antibiotic drops and anti-inflammatories. Well, it wasn't really helping me to even do true charity care on patients because I can now elect to do that, which is very gratifying now that I'm opted out of Medicare and third-party free. When my patient's drops, this patient brought his drops in, and these were $597 for 3 teaspoons of drops. So I had found that I was spending more of my time trying to tell the patients how to get coupons, how to get rebates. The average physician spends about 29 pre-authorization calls a week, 21 hours of staff calls a week trying to get patients their medications with prior authorizations and step edits. So we finally turned to, because we can't dispense in Texas from our office, we finally turned to a company in California called Imprimis that will compound. It puts all those drops in one thing, and they'll send it to my patients' houses for $40. I had a patient this morning that I did surgery on yesterday, and I had written her for a generic antibiotic drop all over the thing, and she got a generic antibiotic drop and a bill for $168 for a teaspoon of drops. I went on Andameds that I learned about from Dr. Umbehr, and she could have gotten that very same bottle of drops for $40. I can dispense, I can have a patient come in for an emergency. They don't have to go to the urgent care, the ER. I charge them $45, which is less than their copay, and they can get an antibiotic drop in a bottle for $5 or a generic tube of erythromycin ointment for $9. But instead, if they have to go through their insurance, they're delayed, they wait. So this is something I really need to get my patients the drops that they need. I need it for glaucoma patients on an ongoing basis, and that has been to the tune of hundreds of dollars of difference in what they could do. I had a 90-year-old patient yesterday, Medicare patient, who still chooses to see me, and he uses a low-cost glaucoma drop, but he has to drive through the pharmacy every month at Walgreens. And it would be a lot easier if when he came in, he could just leave with his generic latanoprost. Similarly, young women on the oral contraceptives. My friend from San Antonio, Dr. Ingrid Skopp, who spoke up here recently, even as an OB-GYN, when you leave, if you could get a generic, your year's worth of your oral contraceptives, that's going to save a lot of trouble because it's hard to go to the pharmacy every few months driving through CVS or HEB or whatever, and then having to pay multiple times as much as you could. So for those very many reasons, I think it's just essential that we have the ability to do that.
Do you think, since you brought this up, let's talk about it. It's like the jury is instructed to do it, as opposed to disregard. Do the two of you believe that medication adherence by the patient will be affected by Representative Shaheen's bill? Because, yeah, we're talking cost, and we have to keep talking cost, but I also want to talk about adherence.
I definitely think patient adherence will improve significantly, which will decrease downstream costs drastically.
Right. Avoided
as well.
cost. Yes,
avoided costs. Studies show just managing your blood pressure can decrease your long-term risk for stroke by 80%. I believe that was done with lisinopril and hydrochlorothiazide medicines combined would be under 2 cents. But patients have they're predictably irrational, and they're risk adverse, and they're afraid that, well, if I do have high cholesterol, my friend's on a medicine and it's very expensive, and so I'm just even afraid to go get checked. We remove all of that barrier when you find out it's less than $3 to check your cholesterol, and I can treat it with simvastatin 20 milligrams for $3.65 a year. It costs more to ship the medicine to the patient if they're farther away than the medicine itself costs. And I think that speaks to how innovative the solution can be. Now, they can leave with the medicine. They don't have to pay at the time of service. We've removed all those barriers to say now you don't have to keep following up. If your insurance changes, your employment changes, this is no longer a burden to your family because you're paying outrageous marked up CVS prices. Recently we were meeting with Seema Verma, the administrator for Medicare, and just on the difference between the wholesale cost of Lipitor, what the $11 average Medicare patient copay is versus the 7 cents a pill the wholesale price is, that savings alone for Medicare would be 12% of the Part D budget on one medicine. I think we'll see a significant increase in patient compliance. It's cheaper, easier, better, faster, and that means more preventative health downstream, more avoided costs.
Do you agree, Dr. Helt?
I absolutely agree because, every year when, even including Medicare patients, if they're on a Medicare HMO or whatever it is and it changes and their drugs benefits change, the cost of their glaucoma drugs, for example, which are a chronic medication that I use, continue to go up. And I've had numerous patients just say, I cannot afford it anymore, and they've gone off it, and they've come back a year later off medications with visual loss. Now we've got people that are visually impaired, losing visual field when they could have gotten it in the office. And I always tell them, here's your prescription. Let's see what we can do with rebates and coupons and through your insurance. You're paying for that, let's use it. But oftentimes, it's even more expensive to try to do that, and we at least need to get them an affordable alternative that they can walk out with. It's extremely important.
Let me ask, since we'll get to the hard stuff right now, which is, okay, it sounds good. What downsides might there be or are there to physician dispense? And I'm going to throw this to Carter and see what he says.
One of the things that we're most concerned about is potentially having physicians charge more at some point. There's been some studies out of California, which no one here in Texas ever wants to use California as an example.
Please don't.
Yeah, I know. But they've actually had to enact legislation that actually kind of restricted physicians on how much they could charge, because they saw upwards in some cases 4,000 to 5,000% markup for that. That's one of the challenges that needs to be overcome. The other issue that obviously is having a physician dispensing model and having it where the patient's getting it directly. One of the big concerns from pharmacy obviously is going to be a safety concern, which they have had studies that say there's no difference in the safety. However, how much is that going to cost the society for a second set of eyes to look at something? And that's the risk. That's why we have computer systems and how the prescriptions come to one spot potentially. We've worked very hard as an industry to reduce polypharmacy, which is the use of multiple pharmacies, because people are going here to this one because it's a cheaper price, and they go back and forth, and you end up missing potential interactions or duplications. Even in my practice, I've seen many a times where a cardiologist is prescribing a brand name blood pressure medicine because they had samples, but their primary care is also giving them a similar medication within the same class, and so there's a duplication, and we usually can't catch that. And so they were really hypotensive, they were really low blood pressure, they were dizzy all the time, and had a lot of fall incidents. We never could figure out why. We were on the very low end dose of a medicine that shouldn't do that. That's one of the risks that we have, is that because there's no communication between the two groups, just in case if someone is going to another doctor, because we have one doctor doing this medicine, another doctor doing this, is that patient going to communicate to the prescriber as to what all they're taking? I can tell you right now, most patients don't do that. They don't know what they're on. As much information as an independent pharmacist as I give them little cards to tell them all there's a little printout the computer can do that says everything that I have. I say, take that to your doctor. Take that in there and let them look at it so they can see what other medicines from other physicians they're getting. That's one of the risks that I'm most concerned about. One of the other things I keep hearing, and as the lone independent up here, and I have to be respectful of my other colleagues in the industry from the retail side, is an independent side, we don't do that. I hear a lot of CVS and Walgreens, and we're not going to pick on those if there's any out in the audience, but they have a completely different price model than, say, an independent pharmacy does in terms of how to help patients with costs. There's been many times I've done, for the most part, cost on stuff. I mean, no markup for me at all. It's literally just paying for the medicine for someone who's in special needs or has issues. So there's options out there for us other than a potential scope of practice type issue for a pharmacist and physician dispensing.
To add to that, I think it could feel like we're against each other in that sense because we're doing wholesale meds, and that's obviously your specialty. But it's really not. I think, not to pick on the retail pharmacists, but they are, I think, the easier one to pick on, just because of the markup. So I would welcome legislation that would stop a 4,000% markup because I think that would kill the retail
If I may
market.
interrupt right there, which is, isn't the solution, I'm probably going to get applause from my colleagues for this one, isn't the solution to what you just said the free market? That is, if somebody, not you, I'm not picking on Carter, but somebody else, some doctor raises his rates to 4,000%, hell, I'll go to the pharmacy.
Yes, exactly. Transparency solves everything there. And if the third-party payer system works so well, we'd see it at the grocery store or the gas station or really anywhere else, and we don't. And I think what we can do is show how we're all on the same side here. Independent pharmacies could develop a membership program as well and innovate and decrease their overhead and their hassle. We share a common enemy with PBMs, pharmacy benefit managers, which are really the key driver of most of these costs. Pay-to-play type scenarios where the pharmacists are a bit over a barrel there. Thankfully, the law that banned the gag clauses there, so pharmacists, specifically independent pharmacists, will have a lot more leeway. The less time I spend dispensing meds, the more patients I can care for. So if there is a doctor shortage, and there's some numbers we can review there, then that means we can offload that work to an independent pharmacist and work in combination. But at the end of the day, we're both small businesses helping other small businesses. If we can decrease the insurance premiums by 30 to 60% for small businesses and improve their access to care, then we should. If the pharmacists don't innovate in this direction, then patients will continue to be left behind. So I think the free market aspect of this, more people dispensing medicines who are appropriately trained, the more competition we have, the more transparency, the more it'll drive prices down, if anything.
The competition aspect, I would slightly disagree with on that. Because of pharmacy benefit managers cutting reimbursements, which both payers on the payer side of pharmacy.
Stop. Please explain. There are lots of people who don't.
I will definitely get there. So, in where physicians directly contract with, say, an insurance company, United Healthcare, or something like that, pharmacies will actually contract with what we call a pharmacy benefit manager. And there's middlemen between the pharmacy and the payer system, whether that's the federal government, Texas Medicaid system, or a commercial plan such as Blue Cross Blue Shield. Pharmacy benefit managers are things like Optum and Express Scripts, and there's 3 of them that comprise about 80% of the marketplace. So it's basically what we call it's an oligarchy, Russian term for very limited players in the field, which almost is very monopolistic in a sense, but it's only 3 major ones. So there are good PBMs that are out there. There unfortunately, though, there's several of them that are not really playing very nicely. And one of the challenges that we have is they cause what we call spread pricing. So what the PBM charges the plan is a lot more than what gets paid down to the pharmacy, or even to, in this case, even sometimes even physicians. And that difference is growing, where the pricing for what they're charging the payers is going up, but the reimbursements are going this direction. So you have this real big disparity that's happening between the two. Within the case of an independent pharmacist, I'm seeing our reductions decrease 5, sometimes 10% every year. It's getting to a point to where it's really, really thin. A physician dispensing model, while as little as numbers of prescriptions that could be dispensed out of that and who they're going to affect, I worry about the retail or the rural areas where this is the only access they have to health care. Would a physician dispensing model, if some proactive physician moved into the area and decided to dispense, there'd be one more small piece of revenue decrease that could potentially close an area and have limited access. So that would mean the physician would be the sole prescriber of all the medicines. So is a physician going to carry all the medicines that we have? Now, I'm a small pharmacy. I do about 1,100 scripts a week. That's on the low end, but I'm in a very small rural area. I have an inventory value of about $250,000, and that's thin. That's just to make sure that I have something on the shelf, so if someone does come in, they're not having to wait. A reduction, if one of my neighboring physicians decided to do this, I would potentially, I could potentially close. I'm fortunate. I run pretty thin. I have a lot of good staff, but that's the risk that this potential model could potentially have in Texas, especially in some of the rural areas.
You would challenge that a little bit in the sense this isn't the idea of crony government. The government's role here isn't to make sure that one business stays open and another one doesn't. And again, the pharmacists have the option to innovate in this direction too. If it is a thin profit margin, and I respect that it is, then all the more reason to innovate a solution that's more sustainable. But if prices continue to go up and patients continue to utilize different pharmacies because of coupons and out of necessity to afford their medicine, then having one provider who's able to dispense all of that for them is going to decrease the problems you mentioned. So in terms of patient safety, patient compliance, downstream costs, preventative health, there's not a downside to patients getting more care more often or having more providers in the network. The interesting thing is the state law as it stands now is a physician is able to dispense if there's not a pharmacist within 50 miles. Or 15. Oh, even better. So that it's less of a question that, in terms of opposition, is the argument physicians can or can't do this. They already can, and they're allowed to do this by state law. We're trying to maximize that so patients have more choice, and we're pro-choice there.
We're pro-choice. I'd like to comment just a little bit. Right now, we have about 31% of patients that are not filling their prescriptions. So if we're able to address those patients, they're able to meet that need in our office. That's not taking away any business from any business that's going on, and I agree. Our point is to serve the patient. We have to keep asking our question, who are we serving, the patient or the state or ourselves? And if we're trying to serve the patients, we're trying to serve those 31% that are not getting their meds, and they found that 67% of the time that's because of a financial reason. The third thing is, we're physicians, we want to take care of our patients. We don't want to run a retail pharmacy. We don't have money to stock a pharmacy. We don't want to do that. There are companies there's one called, Easy Dispense, because this exists in 90% of the states. We talked about California earlier. Well, California, they have in-office dispense. And in the 80s, when Texas went very restrictive, California got a letter from the FTC that said, look, this is free market. This should help foster competition, better prices, and better alternatives and innovation. And that's what the United States is about, innovation and ingenuity. Let's find a way to work outside all of this convoluted mess. But back to the people trying to be able to get their drugs. It is shown that within my realm, and if you look at these companies, physicians across the United States that do in-office dispense generally have maybe 15 to 30 medications. 80% of the time they're prescribing from 20% of those medications. That means if I have 30 drugs there, I'm going to maybe be doing 6 most of the time. And they'll be low-cost generic. It's not going to be profit margin drugs. If you make 10% on a $2.31 bottle of Timoptic, you're not going to, this is a group of patients that is untapped, and it's a low amount of money. The way to address the problem from a pharmacy side is that we need legislators, thank you, to stop the PBMs, and we need that on the federal level, we need them to not have an exclusion from anti-kickback law, and we need to protect Texas. And that's why Texas Medicaid spends $3.7 billion a year at $75 a prescription for 44 million people, while Dr. Umbehr, for his million pills they did last year, 44,000 patients, whatever you did.
Almost 23,000 prescriptions, 1.5 million pills across everything we do, averaged $8.73 per month per script.
Versus 75.
Versus 75 for the state of Texas, yeah. Thank you. When we did that research for Kansas, for an example, the state of Kansas Medicaid was paying $400 a month for generic Keppra, which is a seizure medicine, in this case used for children, that we could get for $12. That's not to say, again, that pharmacies are doing anything improper. That's the markup, that's the overhead, that's the bureaucratic hassle. That's $388 of value that's not going to the Medicaid recipient. We're not anti-insurance. We're definitely not anti-pharmacy. We're pro-small business, but we're pro-efficiency. And so that means there's plenty of room for a sustainable profit margin for the pharmacists or for the physicians, while still providing the same medicine for the people who are at risk. Again, we're looking to simplify, streamline, but increase the value that recipients are getting across the board.
I have to, Dr. Held brought up, several have, and I'm just going to do it now because it's one of my pet bugaboos, which is the effect of pharmacy benefit managers on our choice of medication to prescribe to our patients. For those of you who don't know, most in the audience I suspect don't, pharmacy benefit managers are there intended to reduce the cost to a health plan that they contract with. That's their function. And one of the things they do, for example, is they also use not only the least expensive drugs and give us only the options for less expensive drugs, but they also do fail first, which means instead of using the drug that we think is best for that patient, we have to use the one with the least risk, which also has the least likelihood of helping the patient, and that's got to fail first. And then we try another drug with we are allowed to try another drug with a slightly greater risk, but more likelihood of, well, all medications, every medication, penicillin, aspirin, has risks to it, and we have to balance out the risk-benefit ratio for that patient under those circumstances. My point is that the pharmacy benefit manager often gets in the way of what these doctors, myself included, want for our patients because we know that's best for them, and I'm hoping that physician dispense will disrupt that bad connection.
It is true. I have to, when I even write glaucoma drops, they do what's called, step edits, where you have to start them on, like you said. So they'll say, well, you have to show that they lost vision. Right. Okay, now they've lost vision 3 times.
You want them to lose vision.
They have lost. Can they have the new med now? And this is to the tune of, 80% of the PBM market is controlled by CVS, Caremark, who just bought Aetna, Optum. And Express Scripts. Right. They control 70% of the prescription writing, to the tune of $200 well, GPOs and PBMs, about $250 billion a year that the middlemen take out. That money could be returned to the patients. And, you know, the rebates, people talk about the rebates. There's no transparency. The rebates aren't going to the patients. It's going back to the PBMs, the insurance companies, and a tiny bit back to the employers. So, you know, we've got to address that issue.
But eventually, of course, that money is eventually paid by the consumers.
It is paid by the consumer, and the drug companies raise the prices, and it leads to the problems with the small companies that couldn't pay to get on the formulary going out of business. And that's why we have shortages, FDA now 150 shortages of everything from saline to drugs that we had 30 years ago. And there's no reason that in the United States of America that we should have that. And by the way, we don't want to prescribe any scheduled drugs, no opioids, just things in our office, our antibiotics, our chronic meds, things patients need.
Representative Shaheen, would you like to sort of finish this before we get to Q&A?
Sure. Let me burst the bubble now and talk about the political process.
Do we have to? Yes, we do.
So the the real pretty pink building with the dome in the air at the end of the street is one of the most irrational place in the state of Texas, and that's how it is in all the state capitals, by the way. And we're probably a little less irrational than some of the others. So it's always fun to go to a meeting like this, and we're all talking about this topic, and it just makes sense, and why in the world wouldn't this pass, 150 votes, yeses to no, and all those types of things. But the reality is that there's a lot of forces within the legislative process that are against this, even though 46 states already did this, even though there's a financial benefit and a convenience benefit. We haven't even talked about, the needy out there. Think for a moment about the impact on our needy, right? Healthcare access for the poor is always a big topic. Just think for a second. Not only just the dispensing of drugs, but the DPC model that we've been talking about and the impact that could have on that and so forth. But the reality is that it's going to be a difficult process to get this legislation passed. This is not the first time we've tried to do this. And so the bill's already been laid out in public health, and I'm in the process of speaking to each of the members of that committee to get the bill voted out. But then it has to get to the House floor and lay it out in front of that body. Then it has to go over to the Senate, get a committee hearing over there, go to the floor of the Senate, and then at that point, then it goes to the governor. So there's quite a process, and we're done May 27th or something like that. And so if you like what you've heard, what I would encourage each and every one of you to do is to go to the House website, and each of the committees, House committees is there, and reach out to the members of the Public Health Committee and let them know your feelings. They need to hear from you, because I will tell you, if you go to the Capitol right now and you talk to the Speaker, you talk to the Lieutenant Governor, you talk to the Governor, they are all in alignment. This is very much a property tax reform session and a public ed session. Healthcare is actually not really even on the radar, even though we all know what a profound impact that this one piece of legislation will have. So these members need to hear from you. So I would just encourage you to be part of this process and communicate to them. And it's to get across the goal line. It's going to take multiple people.
I have to give a little plug for Texas here, and that is I've had personally, shall we say, political interaction, mainly testifying, in several states and Congress, and Illinois, California, New Mexico, and Congress, and then Texas. I will simply tell you, Texans, now I'm a new Texan, there's more connection between Texans and their representatives, more back and forth, which I think our founding fathers thought was the way a republic should function. There's more of that here, and I would encourage people to do just what Representative Shaheen said. Talk. If you disagree and you don't like it, fine. Speak to your representative about why. My point is, I really have to put a plug in for Texas. More of that happens here than in my experience in the other places.
I only have 30 seconds. I see the time thing.
Yeah.
I always get that when I speak. The time card comes up.
Yeah, for us, it's usually a red light blinking up here, yeah.
I will say about the Texas legislature, like most people don't know this, we're volunteers. A lot of state legislators are paid, Congress, the federal government, they're paid. We're volunteers. So the whole concept of us coming to the Capitol, passing legislation, then going home and living under that legislation is really true here in Texas. And that's one of the things that makes Texas so special. And then we only meet every 2 years, so that's good too, right? You don't have a bunch of politicians in session passing a lot of stupid bills, right? And so,
Like the Beltway.
yeah, the Beltway. That's a whole nother topic. But anyhow, I think it's always important. I apologize for the Civics 101 there, but I think that's really important that we all, take hold of. One of the reasons why the Texas economy is phenomenal. And yes, we're talking a lot about public education, but we have phenomenal schools. We have one of the highest graduation rates in the country. But so on and on and on, all these companies are moving to Texas, on and on and on. A lot of it's just those very basic dynamics of our legislative government, and I pray to God we never lose sight of that.
Let me now turn this over, if I may, back to David Balat. You're going to give this to
Clint. Let's give these guys a round of applause, please. I just want to say thank you again for the work that you do, for the time that you've taken to be here to educate those that are here and those that are watching and that will watch. We appreciate your advocacy and what it is that you do for the people of Texas and around the nation. So now we're going to turn it over to you all. I know that you're on the edge of your seats to try to get a question in. We have a couple of ground rules. One is you must wait for the mic, and Clint will bring a mic to you, and please hold it close to your mouth. And then the other is we play by Jeopardy rules, so please phrase your comment in the form of a question, and we'll have it addressed as best as we can. Any questions? Yes, sir. Oh, I'm sorry. I apologize,
I have the
Audrey.
microphone. Hi, I just wanted, I heard a theme across this panel, which is get rid of the PBMs. So we have legislation for that, and we would ask Representative Shaheen to sign on to that. There's a couple of bills to remove PBMs entirely from Medicaid, and then there is another commercial bill to regulate PBMs in the commercial space. So I just wanted to, I apologize, that was not a question, I had that in mind before you said that. But that does seem to be the problem, the underlying issue here. So thank you.
Clark?
Yes, the general theme seems to be that, of course, the free market is the solution, and pretty much third-party pay is the kind of almost the red thread villain. And how do we sell, though, the American people? Many American families, of course, are paying more for health insurance than they are really for their mortgage, and yet so when they go, to fill their prescription drugs, they almost want to pay nothing because they're paying so much every month. So with the political scene the way it is, with one political party seeming to think that, Medicare for all is the solution, how do we sell the American people that the free market is their friend and that, insurance in some ways is their enemy?
Just to put one number to make sure he's clear, and then I want my colleagues to answer. Last year, the average American family of four spent $28,166 on health care costs. The vast majority of that went to health care premiums. If you're a healthy patient, that means you just took $20,000, which is like a 40% of your gross income, and threw it in the toilet.
I think it's a great question. So we've helped over 600 doctors convert to this model in the last few years. And definitely when we started, it was harder, and it's gotten easier every year because insurance has gotten more expensive every year. And at some point you get the question, to rephrase it, how do I afford insurance and a membership And we would say, how do you afford insurance without your membership? The camel's back is broken, I think, in terms of patients' desire to have, quote, good insurance or do everything through insurance. As it's gotten more expensive and benefits have been cut, they just want to see an objective savings. So if you can objectively go in and say, well, you were going to spend $1,200, $1,300 a month on your insurance, we can help your employer decrease that to $500 or $600 a month. Now you can fully fund your HSA, have a 24-hour direct care doctor, and here's your out-of-pocket likelihood for meds at a penny a pill or such. That kind of savings says, okay, I'm worried, so I have insurance. Insurance is for risk, but if we can educate and moderate that risk through a transparent business model, it seems to be very successful.
If I can just 30 seconds. That is a huge problem. We just talked about how complex this one, we are covering like a fraction of the healthcare industry in this topic right now. And the problem is conservatives are either, get the government out of the way, or we do a very good job of pointing out like Obamacare and it doesn't work, and here's why. We are actually really lousy on messaging on healthcare. Yes. And we got to get better at that. And the problem is, I can be in a debate with somebody on the other side of the spectrum, and literally they have one sentence that solves everybody's problem, and it's expand Medicaid. And that's not the problem. It's a horrible idea. It'll plummet our state it'll slow down our economy. And everybody thinks that Washington, D.C. has this like big bucket of money. If we just expand Medicaid, all of a sudden that money comes. There's a huge impact to our state budget. We will increase all your taxes if we ever do that. The problem is we don't have a one-sentence response back, and we need to get that. And so that's just something that we need to get a whole heck of a lot better at. And again, people on my side of the spectrum, we tend to start lecturing people and tell them about economics, and that's not the answer. Because at the end of the day, it's very fair. It's a very fair question for somebody to come either to somebody in the industry or a policy maker and say, I've got a little child and I can't afford, I got a little child with a healthcare issue and I love that child. What's the answer? And me responding, Obamacare doesn't work, that's not going to cut it. So we've got to get a lot better at that.
I want to address that. The answer, as far as I'm concerned, to how do we respond to Medicaid expansion, it's broken now. Throwing money at a broken system doesn't cause that system to improve or fix. We need to reform what we have now for the betterment of those that are most vulnerable in Texas. The problem that really should be addressed it's the problem of choice. People don't know that there are choices, good choices out there. When they're made aware of it, they take part in those. So I feel that is going to be a big fix. We need to give people the ability to be consumers again in healthcare.
I have two questions. My first question is, how are you going to protect the physician dispenser from the fate of the small independent retail pharmacist who typically has to sign contracts to do the vast majority of their business with basically one of three major dispensers in the United States, three major distributors in the United States. So they basically sign contracts that say, I have to buy 80% of the drugs I'm going to buy from you, and it gives very little leeway to the independent pharmacist on their cost issues. So in other words, a lot of the discussion we've had about PBMs and things like that doesn't deal with the channel of distribution, which is also a major impediment to saving money.
So I would say there's no impediment there when done correctly. I think the pharmacies would be able to opt out of insurance as well. The PBM side is to say, I would say yes, because that's what we've done. Once you've opted out of insurance, you're not tied to any of those contracts. There's not a free market person out there who can say you have to buy 80% of what you buy from me because you won't get my business. So I can purchase from any retailer out there, any wholesaler, McKesson, Henry Schlein, Andameds, whoever I'd like. I have no contract, no requirement, and I get the medicines at a penny a pill. So for us, we have no problem like you're suggesting. So a pharmacy who says, okay, we're going to do the same thing that the doctors have done. We're going to opt out of insurance, which means we're going to opt out of all their rules and regulations.
And I would opt out of business.
It wouldn't, because I would like to have that discussion, because I think there's a very viable model there. If the cost is here and the true cost is here, there's a profit margin in there somewhere. And that's what we're proving. So we can stay in business because we are able to get those meds so cheap and be sustainable there. We do that because we have a membership for care on top of that. A pharmacist could easily do it. There's one in Tennessee that does it. And they charge a low monthly membership based on the percentage of the amount you've saved versus standard retail price. So you might pay a $5 a month membership or a $15 a month membership, but it's proportionate to how much you're saving. So there would be no contractual obligation like that in a true free market. We don't have that problem.
Carter, you want to?
Yeah, I don't know how much time we have for that one. That's a pretty extensive one there. What the question the gentleman was referring to is what we call a generic, which is one of the newer terms. It's called a generic effective rate. It's how much generics we actually have to use within a pharmacy benefit manager. And they regulate. It's not the word I want to use. They watch this. Yeah, they do. They do regulate in a way, but they watch this number of how much generics we do. If they see that drop down to a certain point, there's penalties involved with that, and they're pretty significant for a pharmacy. If I decide with my company to decide, I'm not going to sign a contract with Express Scripts, that would be 40% of my business. That would be a death sentence for
And
me.
60% of your overhead.
Yeah.
No, not necessarily, but it would be 40% of my business. It would be a massive readjustment that would have to happen literally overnight.
Well, but
and I don't think a pharmacy, being that's our sole income, and let's be honest with you, most, our retail side for OTCs, for most average pharmacy is at 5% of the sales. Can't live off of 5% of the sales. A physician's group has other, modalities in terms of making money. A pharmacy, that's our sole one. You remove that, we would literally, there would be no existence for us.
We have no other way of making money. It's unlimited visits, no copays, all procedures are free, and meds and labs are at cost plus 10%, which barely covers our cost. So that's
Right,
us.
but you're still charging the cost for the medicine, right?
Right. No, because we have the membership that makes that sustainable. It's Costco, right? You pay your Costco membership, and everything in Costco is marked up 14%. Yeah, that's their model. 75% of Costco's profits in a good year comes just from the membership. So 10 years ago, when everyone said that an insurance-free clinic couldn't exist, just like you're saying now, in all due respect, they were wrong. And we're proving that now. Now this is the fastest growing model in medicine today, primary care, with a direct primary care, the membership model, and we're seeing it with specialists. We're seeing surgeons go insurance free. So a pharmacist could easily charge a $5 a month membership and provide medicines for 30 cents a month because they would have a pull and a relationship with their patients. And if a pharmacist could hand a patient a medicine in 30 seconds and not go through the hassle factor that is the current PBMs and insurance and approvals and process, they would happily do that. And doctors would happily refer to the pharmacist that makes it as easy as possible for them and their patients. Because now I don't have to wait on hold for 30 minutes for a prior authorization for Flexeril when I get 1,000 pills for $13. I could just send it to a pharmacist.
Warner, I'm sorry to interrupt. We've got a lot of interested folks that want to ask questions, and wanted to give them a chance to ask their question.
Thank you. Representative Shaheen? Okay, Matt, thank you. I have a Matt too.
All right.
First of all, I want to thank you very much because you have in the back of your head about the needy. Because very often, all of the things that you all say, it's admirable, but somehow that component hardly ever makes it to the table. So I am going to get to my question. First of all, because we're moving so much over to the doctors, I wonder about the ethics of it. Because if doctors just have a lot of medicines and they do not give the medicine equally. In other words, they may just give the medicine for the generics to the poor people, or maybe people who are not paying through insurance, or they maybe don't have as much money. How do you keep the ethics from the doctor of getting in the way? The second question is, what about the employment of all of those pharmacy students? I was over at the Capitol a couple weeks ago, and just a sea of white coats, and so they need need jobs. So will you be taking their jobs? The pharmacists need jobs. And so the last thing is, so my question then comes to, can you compare your proposal to universal health care? Because we're still just talking about splicing up an industry versus making it available for everybody. Thank you.
No more questions after that. I can try to take on the jobs question, and then maybe I think everything else applies to everybody else. Let me answer your question from a technology. So I'm a volunteer politician, but I do technology for a living. And so with respect to, so let me answer your question from that perspective. There has been no more innovation in the history of mankind than right now. What we're doing with artificial intelligence, with robotics, with the internet, with applications, we are experiencing really on a daily basis massive disruption of business models, operating models, and jobs. When I speak in front of a group of students, the statistic I love to tell them is 50% of the job titles that existed today, they didn't exist 25 years ago. So the change that's going on is very profound. People are changing careers and all those types of things. So those individuals where there could be job displacement, to your example, the pharmacists, although I'm not really, I think at the end of the day what would end up happening, I'm just predicting, but I think the pharmacy industry is going to adapt to what's going on. They'll change their business models and they'll be perfectly fine. But if there is job displacement, what we need to always keep in mind is from a historical perspective, there's not more just job displacement than right now. I mean, it's profound. My dad worked for the same company for 30 years, and my mom was a public school teacher. And now, the models are different. So unemployment right now, some economists would argue is too low, right? Because it actually reduces quality of service and choice and all that type of stuff. So what I will tell you is that, especially Texans, because I love Texans, we're innovative, we're hard workers, we're smart, we'll make adjustments, and we'll be perfectly fine. I really believe that.
I would like to take that one on, and thank you so much. The physician ethics, my heart and my inclination, one of the hardest things I ever did was go away from insurance because I never had to talk about money with my patients. I was like, Dr. Feelgood, everything's going to be free. Go up to the front, and there's no transparency. You don't have to do anything. And yet they were going up, and they're paying more and more and more and more and more. So it was very frightening to opt out of everything and start a new model, but it can be done. And as far as my ethics, my inclination would be I would love to do everything free for everyone. When I went to med school, I would say, I want to just take care of everyone in the world. But there's the reality of having to run a business and provide state-of-the-art innovation, have the equipment there. It's incredibly expensive. But we do it. And the patients, even though I'm out of network, I see this growing number of people that are uninsured because our scenario has created a whole new group of working Americans that are uninsured because they can't afford it. Those are the people I see. I'm making it affordable to them. They now have a place to come. And as far as the pharmacists, my goodness, we need pharmacists. They don't just dispense. And what's sad, they're the ones that compound and innovate and create new drugs and create new models. They're the smartest people I know. They don't need to be sitting there working at CVS, being employed. Just like more and more physicians are being employed, more and more pharmacists are being employed, the independent pharmacists being put out of business. We need to have a paradigm shift, and we can bring the best innovation, best technology to our patients. We just got to innovate like the Americans have always done, and we'll find a better way to do it.
I think to speak to the jobs, Economics in One Lesson by Henry Hazlitt has a great piece on this. It's easy to look at the jobs may be lost. I agree with what's been said, and I don't think there'll necessarily be a huge loss of pharmacy jobs. But it also doesn't take into account the dog that's not barking. How many other people who aren't pharmacists are losing their job or struggling because their insurance premiums went up 30% year after year after year because we, the providers of care, aren't innovating. Again, I think it's easy to demonize insurance companies, but in this case, it's not their fault. They're not the innovators of care. They're not the providers of care. They're actuarial people. They're risk management. They're not going to come in and say, this is the best way to run a family practice. We have to do that. We have to own that problem so that we can own the solution to that. And if we can decrease the cost of care by 90% and decrease insurance premiums by 60%, that's a lot more people who can do a lot more things and that aren't tied down by their health insurance. So I think ultimately that's a separate way to answer your concern.
To go back to your, no, I was going to go a little longer, but you got a question. Go ahead.
Yeah, I'll make my question quick, and then I'm going to have to actually leave and just leave it to the wisdom of the panel to share with the rest of the crowd. So I'm going to give you my question, but I'm a family doctor, and I got to get back to the office, so I'm leaving soon. I want to address, when I came and testified in front of the committee last week on Representative Shaheen's bill as a family physician, trying to give freedom to Texas physicians to do what physicians in 44 other states are already safely doing. The only real objection that I heard in hours of testimony was from the pharmacy, the person that was representing the pharmacies, and they brought up this objection about safety. And so I want to just ask it as a question, my comment and speech as a question. In the public policy reference that was out front, they do have that where it was studied in Utah, and I want to see if either the pharmacist or Dr. Umbehr can comment on that. When they did study that issue, there were no worse adverse drug reactions when physicians were dispensing medication than pharmacists, and there were fewer ER visits or urgent cares associated with that. So do you have any evidence, or just the concern, do you have any evidence that when physicians dispense, it's worse? Because when it's been studied, from what I see, it doesn't look like that's actually an issue, and that was the only objection that I really heard last week. So thank you.
For pharmacy, it's just with an abundance of concern that we have that could potentially happen. How much is it worth to the industry or to a patient to have that second set of eyes?
I would say the second set of eyes doesn't prevent all of the drug-drug interactions necessarily. Take a patient who's never been on a sulfa drug before, and because they have a UTI, they're prescribed one. It's a bit regardless whether the physician prescribes it and a pharmacist dispenses it, or if the physician prescribes it and dispenses it themselves. If the patient doesn't know they have an allergy, none of us were going to catch that. When the patient has their medicine from a direct care model where they have unlimited 24/7 call, text, email, and they have a reaction, they know right where to go. There are physicians available 24/7 versus in a traditional insurance or medical care or pharmaceutical model. So some of those are preventable, and some of them aren't. But I don't think we hold back innovation just because of a concern that can be measured and monitored. To the representative's point on technology, we don't stop moving forward just because it could be concerning. And self-driving cars could be a problem, but they're proving to be a large benefit too. So we always have this kind of hand-in-glove process when we're dealing with innovation, but I don't think we stop innovation because of a concern that, per the research, doesn't bear a greater risk.
Carter, you were going to answer the question earlier. I wanted to give you an opportunity to address those questions.
It was just concerning the one lady's question concerning about the pharmacist and employment. I'm a preceptor with the state, which means I can accept a student in and kind of as an internship, a part of their didactic and experiential rotations. Come to the stores, and we talk with them. And usually, whenever I went to pharmacy school, I pretty much had my job solidified. Usually about February before graduation, you already had those lined up. Nowadays, I'm having students call me 2 years after graduating saying they need a job. And I'd love to hire most of them. I'd love to be able to put them in the place. Unfortunately, the economics of it from a small business, I just don't have any place for them. And that's concerning to me, that the pharmacy schools, and that's a whole nother conversation to have, and we can have that offline, where they're pumping out a lot of students. And that's another concern, but that's a whole nother economics of it. But I do have some concerns that model would, right now we're already seeing that it's not causing students to get jobs.
But what I would say is you're seeing that problem now when physician dispensing isn't an option in Texas. So the problems the current system is having is wholly their own. that shouldn't be a reason to prevent physicians from practicing at the top of their license and dispensing medicine. Again, they can already do it, so from a safety concern or a pharmacy job concern, if a pharmacist doesn't feel that they can operate in a space, a 15-mile radius, then a physician can already do this. If the current model is unsustainable, I think that makes our point, is pharmacists and physicians can innovate together for models that are sustainable, but if the school's too large or making too many pharmacists, that's one question. If the current model is unsustainable for pharmacists, that's another one, really unrelated to the question of do patients benefit from physicians dispensing wholesale medicines?
We have time for one last question.
Hi, thank you. I'm here as a patient advocate, not only for myself, but every patient. And what I'm hearing is that, as a patient, our health problems and our need to seek, a doctor to care for them is not, our problems are not a pharmacist's attempt to get a profit or to have more, or an insurance company to remain in business. That's not what our problems exist for. We have a problem here. ACA has destroyed the relationship between the doctor and the patient and separated us not only from the doctor, but now from the prescriptions. And it just makes it inaccessible. This is a solution, and it's a free market solution. You don't have to sell a patient or a family the idea that, economics is this, and this is how we can solve the problem. It's very easy. If you provide the solution, it will work, and we can get back on track. But our job is not to go around and try to help all the pharmacy. Our job is to get the prescriptions we need for ourselves and our children, and that's what we need to focus on. And I wanted to ask Representative Shaheen, where do we stand in terms of the committee, Public Health Committee, and their response to your presenting the bill last week?
Yeah, we laid the bill out, and I'm literally working the members of the committee as we speak. So every time that I'm on the floor, I'm going out and talking to each of those committee members to secure their vote to get that bill voted out of committee, and that's literally where I'm at right now. So what I was talking about earlier as far as reaching out to members of the Public Health Committee, that would be helpful.
Thank you all for coming. I hope you learned something, perhaps. Hopefully a lot. And thank you. I want to reiterate something that was just said. The issues that we have in healthcare today, the inefficiency, the increase in cost, the problems overall, pick one. Everybody here is a patient, and we've all had our concerns and our problems. Those are due to the inclusion of more and more people that are intervening between the relationship of doctor and patient. And the goal of what it is that we're trying to do as a state, as a nation, as a foundation, is to offer more liberty-based principles that will advance freedom for the patient and allow them to be consumers again. I hope you'll pick up on our research. If you have any questions, I think our speakers, some of them will be able to stick around and talk a little bit, and I'm sure there are more questions. Thank you for coming.